Today we will discuss about the anatomy portion of the respiratory system from the first aid USMLE step 1. Basically, the respiratory anatomy is divided into the conducting portion and the respiratory portion. The conducting portion is basically the portion where the no gas exchange take place, while in the respiratory portion gaseous exchange takes place. So conducting portion start from nose and end at the terminal bronchioles. So let's discuss about detail about the conducting portion of the respiratory system. Basically, it starts from the trachea, which bifurcate into the two bronchi, right and left. Then bronchi progressively divide into the bronchioles and then terminal bronchioles. Basically, from trachea up to this portion is lined by ciliated columnar epithelium, which contain mucus producing goblet cells and cilia. Basically, the function of the mucus, any foreign particle which enter in the conducting portion is trapped by the mucus, and then this mucus is expelled by the ciliary movement of the epithelium. So basically, trachea and bronchi, the only portion of the conducting zone, contain cartilage. The cartilage of the trachea is C-shaped and bronchi cartilage is like irregular plates. Second thing, they also contain smooth muscle. The highest proportion of the smooth muscle present in the bronchioles. Conducting zone is richly innervated by the autonomic nervous system. So they have sympathetic supply as well, parasympathetic supply. Sympathetic system innervated by beta 2 receptor. Beta 2 receptor activate then they result into the dilation of airway. And parasympathetics are richly innervated muscarinic receptor. When they innervated, they dilate the airway, decrease the diameter. So in this way, through the autonomic system, we can control the resistance in the airflow system. Second thing we will discuss about from the respiratory bronchioles, they bud off the alveolar ducts, which ultimately terminate into the alveolar sacs. Basically, this portion is the responsible for the gaseous exchange of CO2 and carbon dioxide. This is the basic structure of the alveoli. Alveoli are lined by type 1 pneumocytes and then type 2 pneumocyte. Type 2 pneumocyte secretes surfactant and also as a precursor cells. Alveolar macrophages, they engulf the foreign particles, and basically alveoli is a thin membrane. So around the alveoli there the network of the capillary membranes. This is the network of the capillaries. So pulmonary capillaries have high content of CO2. So CO2 transfer from pulmonary capillary to the alveoli and less content of O2. Alveoli have high content of O2. So from higher concentration to low concentration, O2 moves from alveoli to pulmonary capillaries. From trachea to terminal bronchioles, airway are lined by ciliated columnar epithelium. From respiratory bronchioles to the alveolar sac is lined by simple cuboidal epithelium. Now we will briefly discuss about the lung anatomy. Basically, human has two lungs, right and left. Right lung has three lobes: right upper lobe, right lower lobe, and right middle lobe. And left lung has two lobes: left upper lobe, left lower lobe. The right upper lobe and middle lobe is differentiated from horizontal fissure, and right lower lobe and middle lower lobe of lung is lined by oblique fissure. So left lung has two lobes: left lower lobe and left upper lobe. So basically these are lined by the oblique fissure. Left lobe has a homologous portion like middle lobe of right lung is called linguala. Trachea is bifurcated at the level of the T4, whereas cartilaginous ridge called carina divide into the right bronchi and left bronchi. The right bronchi is more wider, vertical, and shorter than the left. So any inhaled foreign particle is higher chance to go into the left side of the into the right side of the lung, because right main bronchus is wider, more vertical, and shorter than the left. If you aspirate a peanut while in supine position, it enter into the right lower lobe, while on lying on the right side it's enter into the right upper lobe, and while in the upright it enter to the right lower lobes. So basically these are the uh, things which we will need to understand shortly. This is thoracic cavity. Thoracic cavity anteriorly lined by the ribs and posterior lined by the vertebrae. So the thoracic cavity basically divide into the two portions: lateral segments, two lateral segment which contain lungs, and this central portion, one central portion is called mediastinum. Mediastinum is also further divided into the three portions, but the most important is the middle mediastinum, which contain heart. So these are the intercostal space. Humans have 11 intercostal space, which are covered by the external intercostal muscle and internal innermost intercostal muscles. Basically, so neurovascular structures are arranged in between the intercostal space between the ribs. So they are located at the inferior portion of the ribs, arranged superiorly from inferiorly, like superiorly vein, then artery, and then nerve. So when you give the intercostal block, you have to infiltrate the upper portion of the rib to avoid the neurovascular injury of the thorax. Second thing, we will have to discuss the clinical portion regarding to the anatomy is pneumothorax. Pneumothorax are basically mainly two types: open and tension pneumothorax. Open pneumothorax basically freely movement of air during inspiration and expiration. But in case of tension pneumothorax, uh, the injury act as one way valve. So basically, air enter into the thorax cavity but cannot escape during expiration. So this continue entering of the air and not escaping from thorax, pushing the lungs to the contralateral side, which lead to the mediastinal shift. And if it is not treated, it is a life threatening condition, tension pneumothorax. Let us discuss briefly about the diaphragm. uh, at the structure which perforating the diaphragm at T8 inferior vena cava and right phrenic nerve passing through the diaphragm, and T10 esophagus and vagus nerve passing through the diaphragm, and at 12 thoracic vertebra, aorta, thoracic duct, and azygous vein passing through the diaphragm structure. So these are the basically the uh, high yield cramming portion of the first aid. And second thing, diaphragm is innervated by the phrenic nerve from C3 to C5. Any irritation of diaphragm, so that's why we can feel at the pain of diaphragm at the shoulder and the trapezius ridge. Phrenic nerve injury cause elevation of the ipsilateral diaphragm on x-ray. Anteriorly, intercostal arteries are contributed from the internal thoracic artery, which is the branch of the first part of subclavian artery. Second thing, posteriorly, inter- intercostal arteries are contributed from the thoracic aorta. So intercostal arteries provide potential collateral circulation between subclavian and thoracic artery.